Okay, I did my NCUS project board on pancreatic adenocarcinoma, which is very similar to one of the abdominal presentations that I did in class. I'm going to start out, what is the pancreas? It's a digestive and hormonal gland, so it's exocrine and endocrine. The exocrine function is to help produce enzymes to digest food. This is carried out by the Acini cells. It produces amylase, which digests carbohydrates, lipase, which digests fats, trypsin, chymotrypsin, and some other enzymes digest proteins. The endocrine function is carried out by the islets of Langerhans. These cells include the alpha cells, which produce glucagon, which increases your blood glucose levels, so your blood sugar levels go up. The beta cells produce insulin, which decreases your blood sugar levels, and the delta cells produce somatostatin, which inhibits the production of both of these. So pancreatic cancer is a cancer of the cells that line the exocrine ducts of the pancreas. It accounts for 95% of all pancreatic malignancies. Most often occurs in the head of the pancreas. It has a very poor survival rate, especially if it's untreated. Advanced pancreatic cancer, the survival rate is around 3.5 months. If you get good treatment, the survival rate increases to about 6 months. Overall, with or without treatment, the 12-month survival rate for any pancreatic cancer is about 20%, and the 5-year survival rate is about 4%. So this image shows how the pancreas is adjacent to the duodenum. You can see a tumor at the head of the pancreas obstructing the bile duct, which can have cause many problems. So complications of pancreatic adenocarcinoma include, like I just said, obstruction of the bile duct. This disrupts the normal flow of bile into the small bowel. It can lead to liver and immune dysfunction. Can also lead to possible blood coagulation difficulties, kidney failure, and development of cholangitis. When bile becomes backed up into the biliary tree and liver, it can cause jaundice and pruritus, which is the extreme itching, and also cause a Cavassier gallbladder, which is an enlarged palpable gallbladder caused by a mass in the head of the pancreas. These cancers can also cause, if they get large enough, a mechanical obstruction of the small bowel, fatigue, pain, weight loss, and ascites. Only about 15% of people with pancreatic cancer are eligible for surgery. The Whipple procedure is the most common treatment or surgical procedure done to correct this. It involves removing the head of the pancreas, a portion of the duodenum, gallbladder, and part of the bile duct. The remaining parts of the pancreas, stomach, and intestines are kind of reconnected to allow food to digest. It increases the 5-year survival rate to 21% instead of 4%. If you're not eligible for surgery, though, chemotherapy and radiation are the standard treatments. This diagram kind of gives you an idea of before surgery, how the bile duct, the pancreas, the stomach, and the duodenum are all kind of aligned, and after surgery, how things are reconnected. Okay, diagnosing pancreatic cancer. Lab findings include elevated bilirubin and elevated liver function enzymes and an elevated cancer antigen 19-9. The gold standard in imaging for the diagnosis of pancreatic cancer is CT with IV or oral contrast. Transabdominal ultrasound is the most popular diagnostic tool outside of the US, but is getting more popular here. Endoscopic ultrasound is very good at finding small tumors in the pancreas, and laparoscopic ultrasound is sensitive at finding liver and peritoneal involvement in pancreatic cancer without having to do full surgery. Sonographically, you'll see the double duct sign, which is dilation of the CVD and pancreatic duct. This is very suggestive for a mass in the pancreatic head, even if you don't see a mass. Usually the mass will appear hypoechoic and again in the pancreatic head. Ultrasound is a problem though because the patient body habitus and the amount of fat tissue that they have overlying bowel gas and the amount of pain that they're in can limit the use of ultrasound in evaluating the pancreas. I'm just going to show some images. This is a CT image. You can see how well it stands out, seeing the bile duct, the mass, and the pancreas. Ultrasound, here's a Courvoisier gallbladder, which measures about 15 centimeters in length. A hypoechoic mass with internal vascularity. A mass, and you can see the dilated pancreatic duct. And a grossly dilated common bile duct. And this slide shows an endoscopic ultrasound, which gives a very clear view of the pancreas and a normal pancreas and gallbladder. You can see the head of the pancreas very well. And in this one you can see the tumor very well. It's very dark though. So this just kind of recaps, like I said, the exact same presentation that I did for abdomen, but that's my NCUS board. Thank you.